there are real challenges in delivering care, and many people tend to think of that delivery of care being in a secondary care setting in large hospitals. But the biggest challenge, I think, is in primary care, in getting to see GPs or GPs getting to see patients, in the fact that we've got significant delays in ambulances responding to patients, and we have to find a different way to deal with the front end of healthcare to keep people. Two things: one, to keep people who don't need to be in hospital away from hospital, and two, to be able to streamline a way of getting those people who do have to be in hospital, to get them in, get them through their treatment pathway, and get them back out again. And building new facilities would be a great idea, but the reality is there's not the capital capacity in terms of funding to do that. And what we're talking about today in that digital transformation is, how do we find ways of treating more people with the same capacity and more quickly? And that way that I think sums it really well is the language of patients being able to talk to doctors before they come to hospital, so the talk before they walk concept.
Some interesting points there, both Steve and Danny, very interested in the approach you're bringing. I guess bigger picture, I'd be interested to hear your thoughts or your views as to, if we took a view with a blank sheet of paper and said, if we were to redesign the whole healthcare system, this was how we would, knowing what we know now, taking on board what Danny said about, the estate's legacy we have now, but knowing what we know now, if we had a blank sheet of paper, this would be how we would design a healthcare system. This would be how we would design a hospital. And I think some of the outcomes of that might be things that we could actually implement as it were, a sticky plaster on existing healthcare, existing NHS real estate, existing properties, existing ways of working. And I think what's come up already a lot is around the impact of digital, and we've seen some interesting examples where that is having an impact on the way people both use their real estate and also how they plan for the future. But I think it's more than that. If we're talking about the whole healthcare system as a whole, what learnings have there been, and what could we be starting to implement now instead of waiting 10, 20 years time when we've got the funding to build new hospitals or whatever it is. Have you got any thoughts on that, Danny?
That's a pretty broad subject. But, where would you start with recreating a whole healthcare system? I think that one of the things about healthcare system, healthcare policy, one thing I've been able to observe over, I suppose, the last 27 years, and Steve, you've probably been able to observe this in a similar, much perhaps even longer period, but I did wonder I was going with that. But is that it is cyclical. We tend to reinvent these ideas that we've had previously and then rebadge them, recreate them, and say that's something new. But actually, it's something we've done before. I think we're moving in the right direction with integrated care systems. I think if you look across at international examples, we did a piece of research on this about 18 months ago. On international examples of integrated care systems. One of the key elements to that is really about a systemic view, of all parties working together around the individual's health, effectively, and having a care manager that is, and this I suppose speaks in some ways to your point, Steve, about having access to your doctor or and how the means by which you do that. But the point being that there is somebody there who's effectively coordinating your care. That whether it is mental health, rehabilitation, social care, or an acute episode, that and that pathway through all of those different elements is sort of centrally managed. Another key to that really is centralized funding. As soon as you split the funding of services down into individual silos, it's more difficult for the system effectively to provide that joined up care, because it's fighting around priorities and the way in which it uses its money. And that may not be in a joined up way, or the thinking may not be in a joined up way. I think ICSs are hitting that, and I think Greater Manchester, where it has devolved financial responsibility, it has one budget and it is managing that as an example. And some of the other examples in Muskoka in Canada and others in Alaska and in China where they've done this, The most successful examples have had a single source of funding. But of course, all of these things then, coming back to this digital and technology point, is you need to see how that and that innovation, that disruption, weaves its way into that system. And so it's still about having that central care coordinator. It's still about having that central fund of funding for that individual that's used in a more efficient way. But it's supported by preventative healthcare measures as opposed to reactive. And if you look at the US, I don't say the US is a great healthcare system. Absolutely not in that sense. But an insurance-based model is focused on preventative care because it doesn't want to pay the cost out of curative care because that's really expensive. So they're incentivized to focus on that preventative medicine, that preventative care. And I think that's something that the healthcare system needs to be. And I think digital will take us in that direction as we start getting updates on our watches all the time to tell us that we haven't done our 10,000 steps today, whether you choose to ignore them or you choose to go out and as my wife does occasionally, jog on the spot in the bedroom just to get her steps up for the day, which is a quite bizarre thing to see. But there's those sorts of motivators in our lives that may help us start to consider wearing, being sort of more healthy, and therefore reducing the burden or the need to go through sort of more intensive care pathways in the future. And I think that data, the big data idea has been around for quite a long time, but I think as tech evolves, and I'm talking probably about a 15-20 year time frame, I think we can see the fact that the likes of Philips, Siemens, and the other big the GE and the other big tech firms have already developed this digital twin, where they have a digital twin of you as an individual that has your health records, has your health stats, has any digital pathology that you've had done, has your imaging, and it's pulling it together, analysing, looking at the data of other patients of a similar demographic, similar type, similar disease profile, and looking at potential treatment pathways, potential scenarios of your illness. That tech exists. It's a case of looking at how we would roll that out. And I think as the public start to feel more at ease with sharing their data, and if those of us that have these wearables probably need to be aware that we are sharing our data at the moment, whether we walked into that or we've done that willingly. But that will start to drive a sort of a much more sort of holistic view of the individual health as opposed to the population health, I suppose, in that sense. But yeah, it feels like a bit, as I said yesterday, I think it feels a bit Star Trek-like, but I don't think it is. And I think if you think of the time frame between, the people starting to have what was a sort of a Nokia mobile phone where you could play the game Worm, just about, to the period of time that you had a smartphone where you could video call your friends and do all sorts of stuff. That's weaved itself into the fabric of our society without even really realizing over what was actually quite a compressed period of time. So I think, although it sounds a bit crazy, the reality is that will weave more and more into the fabric of our lives, and we will move in that direction. Healthcare will have to move in that direction.
Yeah, I agree. Yeah, I guess for myself and probably being the age I am, but you sort of feel that I prefer healthcare. There's a lot more digital and using wearables and I guess work towards and that, so saving this sort of travel and what I have to do. It's kind of how I prefer it. So I guess others have grown up with technology sort of being more normal. I guess we were just talking earlier about how electric cars were once sort of seen as a future thing, but now they're sort of a lot more common. It's just, I guess, how technology, as it proves more beneficial, is working in so it becomes normal within healthcare as well.
Yeah, I think so. I mean, I think electric cars is an interesting idea. I think milk floats, electric milk floats that then you picked up and recycled glass bottles. So we sort of lost somewhere along the way, and suddenly we're coming back around and thinking, oh, actually, that's a really good idea, isn't it? Yeah, it's quite sustainable. So I don't know, some of these things don't feel that modern, but I mean, I think there is an issue about digital equality. I don't want to focus on digital a lot, really, but I think if in terms of the future of healthcare, I think this is a big disruptor. I think it will impact, therefore, then the spaces that we need. I think I always have to caveat this with the fact that I do think we have a problem. We don't have capital, but we have a capital spending problem that we need to address, and that is, and with a COVID backlog, I think we are going to continue to have that issue. So things like transformation of virtual wards, for example, people feeling and enabling people to be at home, which is probably a better place for them than being in a potentially noisy, busy ward, to recover from their illness. Absolutely, you know, that those sorts of things we're already doing, aren't we? And I think it's more about how you sort of build on that, and those sort of transformations, and continue to do that. That alleviates an initial problem, but then how does that then translate into the future healthcare model? And I think that's another interesting point, that we probably need to sort of think about and touch on. But and again, there's health inequality, and I think there is part of that. You know, is there a different generation that doesn't use this tech? Possibly, yes. So, you know, is there inequalities in terms of people live in rural areas, as I do? But we've, you know, similarly, this rural area that I'm living in, you know, trialed telehealth probably a decade ago, and was one of the sort of vanguards of looking at how that could work in rural areas. Is there an age issue? Yeah, I hear that, and I think that will continue. But I have 78. My parents are 78, 79 years old. They have a Samsung smartwatch and a smartphone. I know that's not every 78, 80-year-old person, but some do, some don't, you know. And I think that as time passes, you will see this generation that is living with this, expecting this, almost this sort of culture of expecting this to be available to you, as opposed to it being something new that you're trying to adapt to. I think is an interesting point.
I think equity of access is an interesting one that comes up time and again. As you say, the whole age thing, it feels to me as though that's a bit of a convenient kind of blanket to put across what is actually a whole host of interconnected and complex issues around, you know, might be low income households, it might be availability of broadband, as you say, because of rural areas, it may be a skills and training issue. There's probably a whole load of different issues around that. And at the same time, there's also what I always think of is, as Shane alluded to earlier, is the whole point of patient choice, the ability for an individual to choose their pathway, the way they want to connect with whoever it is, whether it's their GP or a specialist surgeon. Go on, Steve, you're about to chime in.
Yeah, I was listening to the conversation, which has ranged far and wide. There's some things that strike me as being appropriate. Henry Ford was once asked why he developed the Model T Ford. And what he said is that if he'd asked everybody what they wanted, the answer would have been faster horses. They didn't want a car, they wanted something that got them from A to B, and they understood really well what a horse and cart did. And what they actually wanted was a faster horse. Henry Ford ignored what people wanted and built something different. And I think what we're talking about is very similar. The conversation we had about cars, electric cars, the Tesla is exactly the same as a Model T Ford. It's got a wheel on each corner, it's got a steering wheel, it's got a pedal to press to go faster and a pedal to press to stop. It stays on the road. It does nothing different. And the only difference between the two cars is the fuel source. We're still talking about capital investment in major hospitals. And if one has the temerity to suggest that we close a hospital, move a hospital, reduce the size of a hospital, the resistance is phenomenal. If one has the largesse to suggest that we build a much bigger hospital in the same place without changing anything, then everybody in the world wants to protect that. But healthcare is no longer delivered in the way it was in 1947. And I don't think we should be looking for the same solutions that we had in 1947. And as an example, I would give, I've got a friend who runs the CPAP service which is the service that people use at night, people who have sleep apnea, that help them sleep. And he runs the CPAP service for most of the east coastal states of Canada. And he runs it from his office, and he takes all the data and all of the information from all of the patients in roughly 50% of Canada, runs it through algorithms using AI, and the AI automatically titrates the ventilators in people's houses to change rhythm, rate, oxygen saturation, to change people so they continue to have a good night's sleep. And I genuinely think that that's an innovative, significant change using digital technology that's improved people's lives. I think building bigger hospitals, spending more money on capital, and having more intensive equipment is one half of a solution, but the other half is primary care. And I would suggest that the biggest challenge we have at the moment is not in secondary care or even tertiary care, it's in primary care. Primary care, most people that I talk to on the bus would say they can't get to see a GP. When you go to an accident department, they're completely overwhelmed and they want to improve their access on a daily basis, as well as knowing that in the background, we've got these super places you can go to for ongoing treatment. I also think that for the first time in the NHS since 1947, there is a significant need to split emergency care from elective care. For the last 30 odd years, we've had a situation where we cancel operations on the day of surgery because our elective care beds are full of emergencies. That's getting worse, not getting better, and I don't think we're doing enough about it, and I think we could use better primary care and primary care through improved technology to change that.
Interesting. I guess I'd be interested to see either Daniel or Steve, you know, we're talking about bigger picture and longer term changes. Have you seen any, I'm going to say Heath Robinson, I don't know if that's an expression everyone will understand, any examples where people have kind of made it work? They've made changes on a local basis, you know, using something that's a bit kind of back of the fag packet, a bit kind of self-improvised, but that ultimately delivers some of the change that we need to look at for the longer term. Because I think that's where we've often seen changes happening in the other side of the space store, where I spend a lot of my time, which is working with our corporate clients, working with the tech companies, the finance and legal companies in their workspace settings. We often see the first change actually comes with the users of the space making some changes themselves, you know, shoving some desks across in a different configuration or just using the space in a different way. But that's come from within, that's come from people thinking, you know, we need to change. And that's really what we're talking about, is a change from within rather than an externally imposed change, which often, I wouldn't say usually, but often doesn't have the success it might have because you're trying to change behaviour.
Can I comment on that?
Sure.
Everybody in the country saw that in March 2020.
Yes, true.
What happened was that at one point in time across the entire country, we closed the doors to general practice. We closed the doors to dental practice, and we closed the doors to all the ophthalmic outlets. Dentists still haven't reopened properly from going back to the first lockdown. The GPs still aren't working the same way that they were in December 2019. And they just changed everything on day one and made the best of what they had for healthcare professionals. And because it wasn't thought through, it didn't work for everybody. And there are lots of stories of where it went wrong and how we could have done it better. But the reality is we did the best with what we had. We responded as quickly as we could, and we always trying to be patient focused.
I think that's really interesting. Pretty Steve. I was with the, I mean, and I think it something like a pandemic like that was, maybe a generational thing that suddenly, became the disruptor that forced change. because I think prior to that, you know, we've been talking about telehealth for sort of felt like such a long time, and yet it was always in the too hard box or never catch on box, or you know, and I think, you know, this suddenly forced the agenda. And yeah, you know, we're hearing that the new hospital program, as an example, is talking about 30% virtualized appointments as a sort of minimum target. You know, that's what we're doing moving forward. I think it was probably up around the 80-90% level. You know, you're seeing senior consultants coming in and effectively triaging acute referrals before they're seen at outpatient, to actually sort of, you know, understand whether these patients really do need a face-to-face, even a sort of cross-check virtual, or was this just a sort of a GP, not lazily, but thinking, I just want to refer this, you know, to be sure. A consultant might review the notes and say, I don't need to see them. And I know of a consultant in Oxford who'd drastically reduced the outpatient just by outpatient demand, just by effectively triaging those referrals without actually seeing the patient. So, but the big consequence of this, and we can't forget, is that yes, everybody did have to change in a different way, but now we have a backlog, and now we have a recovery to deal with. And so whilst it did change those you know, those ways of working, and it's in many cases for the better, you know, we're now seeing problems where, and I agree with your point earlier, Steve, completely. You know, where's the social care beds? Where are the community care support? Where's the package of care that is, you know, we're seeing the NHS being blamed for effectively having queues of ambulances outside, but this fundamentally is a flow issue. If we don't have spaces and care pathways in the community, then your ambulance stops at the door because it can't get patients into the hospital, because we have lots of elderly and infirm patients that don't need to be in hospital. They need to be in the community or their homes or in care homes and supported care, again, which can all be done digitally. But again, as you know, looking at the Institute for Physical Studies are talking about a capital, and I know you don't like the sound of this, Steve, but I'm going to say it anyway, a capital investment requirement of in the order of 26.4 billion just to get us back to pre-pandemic waiting list levels by 2025. That's now, you know, a new hospital program was being talked about with 4 billion. So these things don't marry up. So, you know, we have to accept ourselves that, and I think, Steve, you mentioned this yesterday, you know, there was a time where, you know, the waiting list levels were at what was felt a norm, and it was an extended period of time. That time came down and down and down, with so much money being thrown into the NHS. Let's get it down to 18 weeks. You know, we're starting to creep, we're moving away from 18 weeks again, in quite dramatic fashion. How do we get back to that point, if that's where we want to be? Or do we accept that's not where we're going to be anymore, because we don't have the capital, because we've got to pay it all back for the money we spent during COVID? There's some questions there that I think are much wider sort of high level policy issues, but you know, it drives really back into this thing. You know, again, if there isn't capital and we've got a backlog, then we need to look at alternative ways of doing things. And that goes back to your Henry Ford analogy. You know, okay, what we want is more beds, because that's what we need in acute, to sort of, because we've got so many people in beds that shouldn't be in beds. Well, that's not the answer. We need to invest in our community and social care package, and some of that is technology enabled package of care rather than more beds. You know, I think the healthcare systems are always measured by the number of beds, and for good reason, but there is a different way, and I think that's something we've got to focus on now with a laser focus, really, to get us through what is effectively this recovery phase and into what is the future.
I don't disagree with requiring investment. My concern and my worry is where, if one goes back to when Gordon Brown and Tony Blair were in power, we spent about £40 billion a year on the NHS. And here we are 14, 15 years later, spending 4 times that. Now, that level of continued investment is not sustainable. We have to change something we do. I think we should continue to invest heavily in the NHS. I think the future of NHS is in improved diagnostics and then treatment. I can't believe that in 2022, we still have patients turn up in acute hospitals on a pathway referred from a GP without a full diagnostic workup. But we still do. And I see it all the time in hospitals, with significant queues in imaging, in pathology, in blood workups, and all of that should be fairly simple and fairly easy, and should be done in the community. And community, the changes in development of community hubs, so we can do full diagnostics on the high street as and when we need them, and get almost instant results, strikes me as the future. So that the people who end up in hospital are the people who need secondary care rather than primary care. And my concern is we're just doing the same thing as we were doing in 1947. We're doing it much better. Our diagnostics has improved significantly. Our morbidity and mortality rates have improved significantly, but we're all getting a lot older. So the general public is getting older, and there's more and more demand, and we're not equipped to cope with it.
Again, it comes to that sort of, so there's a lot of talk of left shift, you know, moving stuff out of the acute into the community and hospital on the high street. Again, you know, this is great in practice. They need investment as well. But there are lots of examples of you know, a floor of a department store, an empty floor of a department store being used and turned into consulting pods, turned into diagnostics. You know, not a fantastic environment because it's developed as a shop, so you know it's all about lighting and no windows. But the point is, you do that, you're providing a level of convenience to patients. They're not going into an acute setting; they're going to their local high street, and that's where they can get those diagnostics. Again, just sort of playing the advocate around the digital part of this. Anyone would think I was a digital expert. I'm completely not. But I did write a paper on the use of AI in radiology, and it's really interesting. You know, again, Steve, getting those instant results, effectively AI triage, which is now in many respects, particularly in radiology, more accurate than a human reporting an image. In a radiographic image, you can do that in 3 seconds. So you think, you know, we do have workforce shortages in radiologists in the UK, probably about 30-odd thousand vacancies unfilled, but AI can play a part in all of that. You know, it can start to you know, it's not beyond the realms of the possibility that you don't even have to have a member of staff there. You go into a pod, there is some level of remote, you know, conversation perhaps with somebody. There are all of the diagnostics there that you can be involved in using yourself. You know, we are capable humans, most of us, so we should be able to empower the human to be able to do these things for themselves.
I agree on 100%, and it's not just imaging, electrophysiology. We can have significant AI input into things like determining outcomes from 24-hour, 48-hour, 7-day scans. We now have, as you say, wearables. I've got a really good friend who's a doctor who's got asthma. He bought a little gizmo that he blows into every day. It uploads to his phone. He sends it off to his asthma nurse. His asthma nurse tells him how to titrate his inhaler. He's a smart boy, but he still does all of that, and he still gets all of that information back and keeps in touch. Same with rheumatology. Yeah. All of the things are changing the world, and we should invest more heavily in them. We should get better and better at it. But what we need to do as well is to stop our dependence on the big hospitals.
Yeah.
Just going to change tack very slightly there, Steve. It's a fascinating conversation. Just got a question coming from Regan in the audience. I can, yeah. So he's asking about using integrated community care hubs as an alternative to traditional healthcare approaches. So those of you in the audience, we've just got the question up on the screen, which is why we're putting it across. Any thoughts on that, Steve?
Yeah, I think that's absolutely spot on from my perspective. And there are 2 types of community hubs that we're developing. One are about community diagnostic hubs, and the one here that Regan's brought up about integrated community care hubs. That's exactly what I'm saying, that make the treatment more appropriate, closer to home, more accessible. Stop having this division between primary care, secondary care, and tertiary care, and integrate services at a local level, people. And I think using digital, the idea of I have sleep apnea, I need a machine at night. I don't ever need to go to see a doctor because my information is zapped to the local hospital. Or monitoring implantable cardiac devices, so ICDs or pacemakers, having all of that stuff, I think makes huge amounts of sense in doing all of it locally.
So really, maybe it comes back to one of the points I think Danny alluded to earlier around investment, and maybe really what we're talking about is investment in the right areas, not just throwing money at the system.
Yeah.
But this is smart, intelligent investment around, you know, things that are going to make a difference that will transform, maybe over time, maybe immediately transform how the system currently operates.
And also, let's not forget, NHS Digital are doing this. There's some NHSX, there's some incredibly smart people there who are changing what we're doing and why we're doing it, and the way we're behaving or we're acting. I think sometimes we don't see all of that going on because it's happening iteratively and it's happening slightly in the background.
I think it's just, you know, a huge public healthcare system is not going to transform overnight, and it's a massive, massive undertaking to do this. And I mean, again, another part of this is an integrated patient record. You know, as I mentioned earlier, that digital twin idea. You know, all of your data about you as an individual, and you know, in the future, why not all of your data downloaded from your wearable device, you know, whether it be a commercially available one or an issued one from a healthcare system. But the point is, you know, that's another key part of it. No one really feels that, sees that. It's not a tangible thing, but it's an absolute vitally key component to making a system work more efficiently. So I think the trouble is, you know, it's, as you say, there's so much going on at NHSX as an example, but you're not going to see instant outcomes because it's such a massive system to try and change. And you know, it's like turning a super tanker around, right? You know, it's not something you just turn the handle, turn the steering wheel right and turn around. It's a big project.
But taking some examples from that, I don't know what's happening across the whole of the health system, but Northwest London, Imperial College Hospital has the largest dialysis unit in Europe, and they've got an incredibly impressive technology system, IT department, and they've done what you're talking about, Danny, about having that digital record, so that people who are having dialysis can actually log into their own system, patients and carers, look at what their blood results are, titrate their dialysis machines at home if they're doing home dialysis or having it done on site. And I think that we are starting to have those digital outcomes. I don't know of all of them in the UK. I do know that Northwest London, as an ICS, has some impressive systems already, getting better, needing to improve, but big stuff. Can I pick up one more thing and quickly, and that's the using beds as a currency for measuring the NHS. I started nursing many years ago, and when I started nursing many years ago, having a simple operation such as a cataract would have required one to lie flat on one's back for, I don't know, 7 to 10 days. Now you don't even get admitted to hospital. So the number of beds is changing and has changed over the decades, and using it as a currency is not as easy anymore because of all of the changes in modern healthcare.
I agree. I think the problem is, again, I've been a bit of a stato today, but a recent study again from Institute of Public Policy was talking about the UK having about 2.4 beds per 1,000 population, and the average in the EU OECD is 4.6. You know, and is that an issue, or you know, what is that partly because we're, as a system, we are actually being more efficient, or is there a problem, or is it both? And I think this is the trouble, that it always comes back to flow, and some of that flow is always linked to beds. But it's very difficult when you're planning and briefing a hospital, and the obsession always feels a little bit to me like, how many beds has it got, is the question you're asked by anybody in you know, some level of authority, a politician, whatever. How many beds has it got? I need to know how many beds has it got, and that's the message we put out to the public, and that just always seems like such a perverse question. It should be more how we delivering care, not how many beds has it got, because the beds should be irrelevant. In fact, the less beds we have, but have a still a functioning hospital, is a measure of success, right? It should, rather than we have a whole huge amount of beds, and they're all full. Isn't that good? No, that's not good. And I think that's kind of it's a different thing around messaging, isn't there? I think.
Yeah.
Yeah, thanks, Danny. Conscious we're come to the end of time. There is a couple of questions that have come in. Don't know if you got any comments quickly, Steve, but probably something we could answer after as well. Don't know if you got any comments quickly on those questions that have come up.
But one of the questions from Roberta from Royal Cornwall is around 28 hospitals nationally still don't have an electronic patient record. I think that's inexcusable, in my opinion. Jeremy Hunt, when he was Minister for Health, said that by 2020 the NHS would be paper-free. And good on him, regardless of one's political affiliations. He was a good Minister of Health and he did have the correct view. We should have been moving away from having paper records to having integrated EPRs. I can't conceive in my head how we're supposed to work without them. So I can't defend the fact we don't have them. I think it's lamentable. I think the people who run those organisations should be ambassadors for us.
Yeah, I think I'd agree. I mean, I think, as I said, a research paper we did on those integrated healthcare systems, an absolute key part of that, apart from a single funding source, was a single patient, patient record that was shared across the system. And how do you have an effective integrated system if you don't have an integrated record, electronic patient record? And I think that's. It's got to be something that is a key driver moving forward in terms of new models of care and digital transformation.
Agreed.
Yeah, that's good. Well, I guess as we come to the end of time, we better wrap up and we'll try and answer some more info on those questions, get them to you afterwards with some input from Steve and Danny, if that's okay. Thanks very much to the audience for putting those questions. We appreciate your contributions. And massive thanks to Danny and Steve joining us, and Alex sharing insights. It's been very insightful discussion, and hopefully giving the audience some things